Thank you, Dr. Bertagnoli. I'd like to thank the Academy and the organizers for giving me the opportunity to make some remarks and be a part of this panel. As a brief introduction, I am a clinician informaticist with a focus on cancer informatics, and I have a few disclosures. I have funding from the National Institutes of Health, the American Association for Cancer Research, and Vanderbilt University. I have consulting fees from Westat, Roche, Milax Tech, and Flatiron Health, and I have partial ownership of hemonc.org LLC. My comments will focus on opportunities for improved research using EHRs, or what is often called secondary use. One of the ironies of this is that the medical record, as originally envisioned, was designed for didactics and the generalization of knowledge, what we would recognize as research today. This is true of the Edwin Smith Papyrus and the Hippocratic Corpus, both well over 2,000 years old. It is only really in the last 100 years that medical records, and then EHRs, became tools for billing, medical legal purposes, and finally, direct patient care. It is particularly within the confines of billing and medical legal purposes where secondary use has languished. And a classic example of this are the International Classification of Diseases, or ICD, billing codes. ICD codes support services rendered. They do not necessarily define a diagnosis. A typical example of this issue is illustrated by one of the newest ICD codes, U07.1, used to identify laboratory-confirmed COVID-19 and introduced on April 1st, 2020, not a joke. Because this code has been used to justify billing for workups, whether or not the patient was diagnosed with SARS-CoV-2 infection, it has poor positive predictive value. Sometime later, the World Health Organization introduced U07.2, COVID-19 virus not identified. Due to the lag, the US never adopted U07.2. It's missing from our electronic health records. Even more importantly, there's no code for COVID-19 suspected, but later we determined it was something else. And so these type of issues are widespread in today's structured EHR data. For example, a recent paper that we published in JAMIA, we showed that fairly routine data such as lab values and demographics are inconsistently represented across EHRs, whether they be from the same or different vendors. And by the way, the elements we looked at are all M-code elements. I want to take a minute to talk about an entire field of research that relies on the existence of unstructured narrative in the EHR, and that's clinical natural language processing. You've heard a number of folks mention NLP. I'm not going to go over what it is, except to say that it's a broad field that goes well beyond medicine. And one might say, well, if we can get everything in structured format, this field doesn't need to exist. But I'm convinced that we should not move so hastily towards that goal. As mentioned earlier by Dr. Levy in her introductory remarks, an attempt was made in the late 1960s by none other than Larry Weed, the creator of the problem-oriented medical record and the originator of the SOAP note. Dr. Weed and his colleagues introduced a structured medical record at Hampton Highlands in Maine, 100% structured. While this approach enjoyed some limited clinical success and even enabled research, the idea of problem-oriented documentation spread, but the structured approach did not. Others, much wiser than myself, have written about the tension between narrative and structured text in the EHR, and I believe it's a necessary tension, and I think we'll talk about that more during the discussion. Besides that there's this ongoing, what I believe to be a legitimate need for narrative in the EHR, the field of clinical NLP helps to advance the general science of NLP, given that it tackles one of the most complex domains of human written discourse. Techniques developed to extract and normalize information from EHRs have been at the cutting edge of machine learning and artificial intelligence. For example, the NCI has an active collaboration with the Department of Energy to utilize Summit, the most powerful supercomputer in the United States, to extract cancer information from pathology reports. And I'm sure you'll hear more about that tomorrow from Dr. Lynn Penberthy. Structured or unstructured, research using EHRs faces a bigger problem, which you've also heard a lot about, the fractured state of clinical care and the general lack of interoperability. A patient's cancer journey can happen across years or decades, across geographies, and across healthcare systems. My friend and colleague Liz Salme has this lived experience, and I recommend that you learn about her challenges in bringing her EHR data with her when she had to change healthcare institutions. We can't conduct truly meaningful research if we don't have the complete and machine-readable data available. Salvaging should be left to American pickers, not to EHR researchers facing a mountain of fuzzy faxes. There are some amazing research opportunities ahead of us if we can create a truly advanced EHR ecosystem. I'll just briefly mention two. Again, you've heard about these. Patient engagement and omics integration. First, patient engagement. Patients know their symptoms best, and patient-reported outcomes should be routinely collected, integrated into EHRs, and should supersede the clinician-gathered review of systems in most cases. Patients should also be able to leverage their own data to make discoveries that may not have been evident to their clinical team, and these discoveries should make their way back into the research commons. Genomic and other molecular information must be integrated into the EHR ecosystem as well. States should mandate the reporting of next-generation sequencing results to central cancer registries, as I believe is already happening in California. Precision oncology can't happen without marrying the phenome and the genome, and the EHR is the logical place for this to happen. Thank you for your time. I will pause there and look forward to the discussion.